Many thanks for staying with us here on News Desk this morning. And we'll be returning to Alisa Hotel for that very forum on that controversial bill that seems to have gotten quite a number of people talking. But let's now turn our attention to health. And effective today, that's March 1, 2016, health service providers under the National Health Insurance Scheme will enjoy an upward price review of between 24 and 27.5%. Now, the increment, according to the Insurance Authority, is due to concerns from health service providers on the increase in healthcare costs. Now, to help us understand what this really means, as well as the numerous reforms currently being undertaken by the National Health Insurance Authority, is Deputy Director for Communications, Salom Adono, who is right here in studio with me now. Salom, good morning. Many thanks for joining us.
Hi, good morning. A pleasure.
So, the health insurance seems quite poised and seem like you really want to change a lot of things in the scheme. Maybe you can run us through a few of them, and then you can tell us about this price review, what it really means.
Well, thank you very much, and a very good morning to your viewers. The health insurance, as we've said many times, is work in progress. And work in progress means that we never shy away from continually improving on what we do. Every now and then things change, and once things change, it becomes the mark of a good organization, or an organization which wants to do well, to keep changing and keep adapting its ways to ensure that which it's doing is relevant to the times. So a few things we've been doing the last few months include the fact that we want to respond directly to some of the concerns from our clients or members. That is, they go to hospitals, they appear lost in the hospital. Nobody is there to talk to them because nurses are busy, doctors are busy, everybody's busy, obviously because of the healthcare provider or health professional population ratio. Very few healthcare professionals in the country and a lot of people to deal with. That is not the making of the NHIA, and I think the system is generally trying to address that. So what we are doing in that respect is to deploy our own staff, permanent staff of the NHIA, to be stationed at these healthcare provider sites so that when they have issues, there's somebody to talk to. NHIS person is there, dressed in NHIS apparel or colors or shirts or cloth at an NHIS stand. You go there, you talk to the person. If you have any difficulty, you are assisted there and then. If the solution is not immediately available, they tell you what to do. So, for example, you go to the facility and you are charged for something you don't understand. Instead of arguing and trying to push your case, which you're unable to do because you are not well, you just walk to the NHIS stand or desk, speak to whoever is there. The person will help you navigate the system, and you have what you want.
Is this not going to come at an extra cost to all of us, really? You're going to get people to man all these posts?
Well, we call it efficiency gains. Let me give you an example. When the new chief executive took over, where with him he did a few rounds in some of the regions, and one of the first observations he made was that there is a certain process or a certain part of our registration process which is to fill forms. So you fill the form at one stage. When you get to the computer, I know it's biometric, so we use a lot of computers. You get to the computer, now you give the form to the data entry personnel behind the computers, then they enter your details. He felt that part could be taken away. So you just sit in front of the person directly, you mention your name, and your name is directly inputted into the system. So that served two purposes. One, that cut out the use of paper in the registration process. We have 11.2 million subscribers. As at December 2015 figures, we recorded 11.2 million people. The cost of paper without the ink and without toners is 50 pesos. So multiply 50 pesos even by 10 million people, you have about 5 million. So if you take out that paper, you are saving the scheme 5 million cedis just by that process. And so we envisage that taking out that process alone will save the scheme close to 6 million cedis and over. That is just that. You've not even costed for toners, etc. So now what happens is that the people who were writing those names of people will now become redundant.
Exactly.
So we will need them elsewhere. We will not send them home, or we are not sending them
so
home.
you're saying
or we've not sent
it
them
is
home.
these people
Those
that we
people
have
are the people we are taking to the provider site. We've trained them, including some of the national service people we have, and a few other people.
So that suggests that the NHI is not hiring any more people to carry out this.
It's not an extra cost to us necessarily, but it's certainly a way of improving our subscriber or member experience, because when they go to the hospital now, they have issues, there is somebody to talk to. We're almost done rolling out in Greater Accra. We are moving to the eastern region. We will roll out till the whole country is covered with this particular thing. So that is one. There's one other thing we are doing. We call it a NAVIS, which I believe will be launched very soon. We call it the NAVIS. The NAVIS simply is a system of authentication.
Okay.
We understand that our card is very popular. The NHIS card is very popular. A lot of people get it. Apart from healthcare, they use it for a lot of other things because it's the most accessible and the most affordable card. So people go to the banks, for example. The banks need a way of authenticating the cards. So our MIS guys, the Management Information Systems guy at our place, have developed an app, which makes it possible for banks and other financial institutions to authenticate the membership. So people don't come with fake cards to take money transfers, etc. How the issue of the Sakawa boys and all are destroying our system, if you like. So that authentication process is at a fee. So the banks get to pay a certain fee to the NHIA, and the NHIA is making money. And all these are new things we are doing to ensure that the scheme is properly positioned, and the scheme also has money from within its own sources to do things it has to do, and a lot more other things we're doing. For example, we are deploying verification kits to all service provider sites. Service provider sites which submit huge claims or are big ticket facilities like Kolebu, Ridge Hospital, Police Hospital, etc. We are deploying authentication kits to a lot of these facilities so that when people come, they are verified. Verified means that indeed you are the right person coming with a card. So let's say if I look like my brother or you look like your sister, you can't bring your sister's card and say you are the person. And that authentication is also an efficiency gain measure. What it means is that you cannot cook the claim. You can't say the person came here for care when the person did not come. So with this, once you are verified, a transaction code, we call it the claims check code, is generated and you see it on the tablet. So that code must be written on the claims form, and we see it at our back end at NHIA. So when the claims are submitted, we must ensure that the code on your claims form matches with what is in our system. Then it means that's a good claim. The person indeed was there. That number cannot be forged because it's a function of the venue, the place, and then time. So you can't forge it. So all these, we believe, will improve the efficiency in the scheme, and a lot of other things we are doing that will be.
Okay, so it seems to be the case from where I sit that, well, the NHIA seems to be working pretty hard at trying to seal all these loopholes and all. But one problem for many is the fact that many of these service providers claim that your monies, one, either do not come in time, or sometimes they do not get the monies they are due.
Well, you're right, and I wouldn't shy away from speaking about that because I've spoken about it many times. Partly so, yes. Sometimes service providers think that they don't get what they are due, and etc. And
the last time we spoke to you, you were in arrears of, I think, about 6 months or so. You were supposed to reimburse some.
We've moved on from there. But have you
made those payments?
Of course, the NHIS cannot make all payments, at all times. We will certainly have to owe, and we will pay, because by the very design of the scheme.
I'm asking whether you've been able to clear that 6 month backlog.
We have a payment plan we've agreed with them. We signed an MOU of a kind, a joint statement of a kind with the Health Insurance Service Providers Association.
So you haven't paid, essentially?
There's a payment plan, and we are on. We've paid part, and there is part. We are following the plan.
How much have you paid so far?
I can't tell you off it, but I think we are about paying 2 months or so out of the 4 or 5 months. There's a payment plan that by a certain time we should be able to clear X amount.
By which deadline?
By March. Ending somewhere. I have to check.
But that's by the end of this month. You should have paid the backlog.
You can't pay everything. There's a payment plan.
Okay.
So by that date, we should be able to clear what we said we will clear, what we agreed to clear.
Okay. What was the agreement?
No, I really have to recap. But I think the agreement was that by the end of that, we should be able to pay about half of what we owe, and then from that, from or beyond that date, we make payments in bi-weekly or fortnight basis, and that plan is on really. So the service providers, to be fair to them, want only two things: one, to be paid on time, and then to be paid the right tariffs. We understand that payment on time sometimes is a function of many things. NHI has a part it plays in it. There are other external factors which the NHI does not control. But what we are saying is, we think we are firmly in control of what we are able to do, and we are trying very hard to meet them there. The other part too is paying them what really is due them, which you alluded to.
Exactly.
What we are saying is that effective today, there is an increase in the tariffs we pay healthcare providers. That means that healthcare providers, will be paid realistic prices which will reflect what the market is saying.
So it suggests that all the while you knew you were not paying them realistic
not necessarily. You see, the reviews are done periodically. So last year you agreed that there were a few difficulties with the economy, and we are in the economy. We are subject to various shifts and difficulties in the economy. So if the cedi-dollar ratio, for example, I mean, it's not so favorable to Ghana or to the cedi, that affects healthcare provision as well, because a lot of these people import medicine from outside, and it's the dollar they use. They buy consumables usually from outside, and it's the dollar they use. So you must start off with a very good price or with a very good rate, but towards the end of it, you know, the rate will no more become nice, and that is when the problem comes. What we are saying this time, and what my chief executive did announce on Friday, is that, you know, today we are implementing the new tariffs and the new medicines list, which are two different documents, which I may explain if we have time. Today too, we are starting the review of this new system or these new tariffs, so that we don't take a long time in reviewing it for the issues to come up again. Because certainly at some time in the year, the situation may change and cost of things may go up. But if you wait for a longer time, that is when those issues come up. What it means is that service providers henceforth are going to get the right tariffs for their services. So if somebody came for a cesarean section or even labor or a surgical operation, and maybe it costs 10 cedis, NHIS will ensure that we pay you 10 cedis or more. And our prices are very competitive. NHIS will pay you 10 cedis or more, so you are happy to provide the service. So our subscribers, who are our ultimate people, are also happy and have satisfactory service.
Okay, so it's good you mentioned this, because one major problem has to do with, like I mentioned earlier, payment that doesn't come in time. So, for instance, for this health service provider who happens to be in a rural community and has performed what he or she is supposed to perform, the institution is supposed to perform, and for 6 months they've not been reimbursed. Now, yes, you are saying that the money is going to be increased a bit, but even for the numbers we are seeing, it takes such a long time for the monies to be reimbursed. And now we are going to have to pay a lot more. I'm speaking of the NHIA. You are going to have to pay a lot more. Is that not going to be a problem, really?
Well, there are always ways of dealing with things. The fact that you're going to incur extra costs doesn't mean that it should disadvantage the service providers. They're also in business, and nobody's in business to run at a loss or to lose. So whilst we are thinking about ourselves in terms of making cost savings and judiciously applying our resources, it is also prudent application of resources to ensure you make realistic payments. As I've said many times, government is the ultimate guarantor of the scheme. It's a social protection scheme. Government instituted this scheme in order to cushion people who are unable to pay by taking money from taxes and other sources, and also taking premiums and having what we call the solidarity principle. People who are strong and can pay will pay. Those who are not strong or those who are weak and cannot pay are catered for in that sense. We call it cross-subsidization. You know, so what that means is that government takes care of about 70% of the people on the scheme who do not pay anything at all. You know, so government has promised that the necessary budgetary allocations will be made to ensure that the scheme continues to be buoyant. But I started by telling you some of the things the NHI is doing by itself to save more money or get more money to support its operations. So that we are doing. And the 2.5% levy that we get from VAT or NHIL, that amount of money expands with the expansion of the economy. And we think that the economy has not been stagnant. Of course, there's been quite a few difficulties, but it has not been contracting. It's been expanding, though it's been expanding at a very slow rate or pace. But in any case, there is some expansion, and once there is some expansion, the 2.5% quantum of the collection of the VAT, which is assigned the National Health Insurance Authority or scheme, will also improve. So we have done the actual studies.
So now let me ask about this. For the ordinary card holder, what he or she wants to know is that, okay, so what does this mean? If I move to a health facility, does that mean I'm probably having to pay more? Or if it has to do with premiums, does that mean I need to pay a lot more for my premiums?
No, we've not spoken about premium at all. You see, I understand that question, and it's a good question, and I think it offers a good opportunity to explain it. When normally we talk about tariffs, the layman's understanding of tariffs is that the consumer is going to bear it, because when you talk about electricity tariffs, it means that the consumer is going to pay more. If you talk about water tariffs, it means the consumer is going to pay more, especially from recent experiences. But when you talk about healthcare tariffs, it is the tariff or the rate the NHIA itself is going to pay the service provider, or the payer or the purchaser, which is the NHIA, is going to pay the service provider. And NHIA is doing so the subscriber or the member will be happy when he goes to the healthcare facility, because the healthcare provider will also be happy providing service, because the healthcare provider will be reimbursed at the right prices. Let me quickly make a comment on the delays in claims payment.
Okay.
The delays in claims payment is unfortunate, and we hope to improve the system. But we cannot get to a point where NHIS pays you ahead of time. You first have to provide a service. When you provide a service, the law gives you 1 month to submit your claim. The law gives NHIA, which is the payer or the purchaser of healthcare, the law gives the NHIA 2 months. That's 60 days. When you put that 60 days together with the 1 month, you have 3 months. So the law allows us a 3-month period within which to vet and do everything and make the payment. So indeed, the service providers complain only when we go beyond these 3 months.
Okay.
And so if somebody tells NHIS owes me X number of months, the next question you should ask is, when did you submit your claims? So when you submit your claim, that is when we start counting. We wouldn't say that your claims was for maybe August and you submitted it in March. So we'll quickly leave everything we are doing and vet your claims. No. The day you submit it, that is when we start counting. It's on first come, first served basis. So certainly we will owe, but we will pay, because by the design of the scheme.
Understand all that you're saying. I just want to know, per this new system of yours, this new scheme of yours, the tariff system I'm speaking of, what does it mean for the ordinary cardholder, really?
What it means for the ordinary cardholder is that the ordinary cardholder will receive a more satisfactory service when he goes to the hospital, because the service provider will be paid at the right price and will be happy to deliver service.
Does it come at an extra cost?
No, it doesn't come at any cost.
No extra cost.
No extra cost to the consumer.
What happened to the premiums? We were told of a capitation system that was being rolled out in, for instance, the Ashanti region and other parts.
The capitation is in Ashanti, is in Upper East, is in Upper West, is in Volta region. There's a plan, active plan, to roll out across the country. Sensitization is started in other parts of the country. The plan is to get the whole country on. What capitation does is that it makes you choose a service provider which you'll be tied to, and that is where you go receive your health care.
So based on what you're saying, if I have a card, an NHIA card, and my service provider happens to be at Kokomlemle, I travel to, say, Tamale, and I fall ill, I can't visit any health.
No, you can't. Nobody plans of sickness, you understand? So when you travel to Tamale and you fall ill, yes, you still go to any hospital available, but you'll be treated the same way you'd have been treated in Accra or elsewhere. The only difference comes between the NHIA and the service provider. You get your service and you go. Capitation is just a payment method. And by payment method, when you go to the hospital and it's free, somebody has to pay for the freeness. And it's the NHIA or government which pays. So you have had your free service, you are gone. The NHIA now has to use a certain method of paying the healthcare provider for the service they rendered or they gave to you.
So you deal with the person I paid to?
No. I mean, we deal with the hospital in that sense, or the clinic. You just go receive your care. Just say that so you are having an NHIA card, you are from Accra. This is not your chosen hospital, but because you are not here, you've fallen sick, you have come. They will take care of you, and they will bill us through a different mechanism, and we will pay. Quickly, NHIA has 3 methods it pays its providers. We have what we call the fee for service.
We must be wrapping up on
we have what we call the diagnosis-related groupings, and we have the capitation. Capitation, you choose it, and you go there, and NHIS pays the healthcare provider ahead of time. The more people you have as a hospital or a facility, the more money you get, because every person has what we call the per capita rate assigned to the person. So if you have 10 people, you have 10 multiplied by the per capita rate. If you have 1,000 people, you have 1,000 multiplied by the per capita rate. What that does is that it brings about what we call managed competition. So go to Ashanti, for example. All the service providers are doing innovative things to ensure that they attract more people to choose them. And by so doing, quality of healthcare is improved, and that the subscriber is happy. If I don't like you because you don't treat me well, I have the option to leave and go to another place. And you know how word of mouth works. If I tell you this provider is not good, you go and tell your friend, you go and tell your family, they all leave, and that person suffers. That's what is happening in Ashanti now.
Right. Salom Adonu, many thanks for joining us here on News Desk this morning. And Salom Adonu is the Deputy Communications Director for the National Health Insurance Authority. He's been with us for the past 30 minutes or so. He's been explaining to us this new system the NHIA is rolling out, including the many modifications they are making to the scheme to ensure that it becomes a lot more effective and efficient. And we'll be keeping our eyes on them anyway and be monitoring whether indeed they are saying what they claim they are doing on the ground there. But let's quickly go to the Ashanti region, where we are told that several members of the New Patriotic Party from the Menchia North constituency in that region have reportedly sustained injuries following a clash between themselves and bodyguards of the party's regional chairman, Bernard Nchubu Esiakon. It's really unclear the reason for the action, but reports suggest that the supporters marched to the regional headquarters after they had waited in vain for their constituency primary to be held as announced by the regional executives. Let's get on to the phone lines now. Speak to Salif Ibrahim, who is the constituency secretary for NHIA North, and he's joining us over the phone lines now. Salif, good morning. Many thanks for your time here on News Desk.
Oh, good morning, my brother.
Yes, and apologies for having you to hold for so long. But the very first thing I need to ask now is really what brought about these clashes in the first place?
Okay, my brother, let me first of all say a very good morning to your listeners and your listeners across the country. What really brought this whole issue is we are still having our parliamentary election not being done. So the party had a roadmap last week, and it was communicated to we, the constituency. And the roadmap was that we are going to have our parliamentary elections on 7th of March, which is coming Monday, 7th of March. And before we will have the parliamentary elections, there were issues with the constituency album. So about approximately around 170 polling station executives were affected. So let me say 170 delegates who are going to take part in the parliamentary primaries on 7th had issues that needed to be resolved. So the resolution that we all agreed on was that we are going to do a rerun on those affected 170 polling station executives who are delegates. So the roadmap was that yesterday, which was 29th of February, we are going to do the rerun on those 170 thereabout people. So they gave us up to 10 a.m. The regional organizer and his deputy with other constituency organizers were ready. They were set that we were going to move to the ground to do the election. Some issues came up from the other faction of the party within the constituency. So we have to postpone.
Okay, we seem to have lost on the phone lines now. Salif Ibrahim, who is the MPP's constituency secretary for NHIA North, he was telling us about the events leading to the skirmishes we are told of. We're told that quite a number of people got themselves in this fight of a sort yesterday over their primaries that they are scheduled to hold on Monday. We'll be bringing you a lot more when we re-establish connection with him over there. You're watching News Desk here on your Joy News channel on Multi TV. Time now for us to do some business with Emmanuel Abojiriafe.